Good afternoon, everybody. It's my great pleasure to chair the session this afternoon and to introduce our speaker, Dr. Susan Lowe from WITS, who's going to be speaking about point-of-care testing in coagulation, which is a topic of very wide applicability from the lab, technologists, registrars, clinicians. Everybody needs to know about point-of-care testing. Dr. Susan Lowe is a highly regarded colleague. She is a hematology pathologist and works at WITS, runs the coagulation lab, she's also very actively involved with research, and in fact has just completed her PhD in the pathogenesis of TTP, which is absolutely fantastic. She is also Secretary Treasurer to the South African Society of Thrombosis and Hemostasis. So we very much look forward to that. Before I hand over to Susan, I've just got some housekeeping announcements. So just to be reminded that all these talks on the deep dive are available online on the Blood SA website, and that you will get CPD points if you attend for at least 60 minutes. You need to attend for 60 minutes to qualify for the CPD points. And just to thank the leaders of this initiative, Prof. Estelle Verburg, who unfortunately couldn't be here this afternoon, Prof. Lowe, who's on sabbatical in Europe at the moment, Gerdien, who is our coordinator, and Melanie, the administrator. So many thanks, everybody, for joining. I'm now going to hand over to Susan. I think we're really all in for a treat, and we look forward to your talk, Susan. And let's just check that you can project your slides and that everything IT is behaving.
Thank you very much, Jessica, for that introduction. I'm hoping that technology plays with us this afternoon, but I just had a quick look and I don't think we're scheduled for load shedding in Joburg until I think about 6 tonight. So hopefully we will make it through. I just want to minimize everybody on the side here so that I can see the slides as well. Does that look acceptable to everybody? Okay, so as Jessica has indicated, I also am going to try and get my pointer up and going here. My name is Dr. Susan Lowe. The other day I introduced myself as Susan Lowe, and all the registrars just looked up and said, who is this person? We don't know Susan Lowe. So I'm actually Susan Lowe, and I am a hematopathologist working for the NHLS, affiliated to WITS, and also representing the South African Society of Thrombosis and Hemostasis. This afternoon, I was asked to speak about point-of-care testing with a specific emphasis on what's happening in the coagulation arena. So the normal testing sequence is very well known to all of us from the day that we were interns, medical officers, registrars, did GP locums. There's the first time consultation where the clinician actually decides about which blood tests are required. Samples are collected, there's transport, porters bring the samples to the lab, a lot of processing in the laboratory with analysis, results finally appearing on a laboratory information system available to the doctor either in electronic or print format, and often the result is only available at the second appointment. And this stands in contrast to the point-of-care testing arena, where the patient almost is standing with the result in their hand at the first point of contact with the medical fraternity. So much so that the WHO has published criteria for point-of-care testing in resource-poor locations. So therefore, we know that this is an area that we all have to pay attention to. There's an acronym, ASSURED, The point of care testing platform should ideally be affordable, sensitive, avoiding false negative results, specific, avoiding false positive results, user-friendly, simple to perform, using non-invasive specimens, so either capillary blood obtained with finger pricks or finger sticks, and urine or sputum or nasal or throat swabs, and we became very aware of those samples during the COVID pandemic. The platforms, the point of care platforms should be rapid and robust, equipment free. We want to almost exclude ESCOM from the testing altogether, delivered so accessible to end users. So the assured guidelines for point of care testing. There's been a lot of evolution, a lot of development in this arena, from first through to third generation point of care tests, first generation simple biochemistry and hematology test results, through to third generation, and we can almost think of third generation testing as being laboratories on a chip. These testing consists of various methodologies, including benchtop analyzers. We have analyzers connected to cell phones, to smartphones or cell phones. We've got fluidics, etc., that's involved. So many analyzers will qualify to be termed point of care test instruments or analyzers. The why of point of care testing. So the why, a point of care testing is bedside testing. We can also refer to point of care testing as near patient testing. And this form of testing offers convenience with faster test results, hopefully resulting in timely clinical decisions to improve patient outcomes and hopefully reduce costs. Point of care test results are available in approximately 3 minutes, and this stands in contrast to the laboratory tests that can take up to 7 days. Some of the turnaround times for some of our screens in the Coag laboratory here at Charles Matkeke Hospital is 7 days. Why this delayed as far as laboratory test is concerned? Sample preparation, quality assurance, batching of testing, and the actual analytic process that can be a lot more complicated compared to point of care. The way. Point of care tests are suitable to be performed almost everywhere. At home, patient self-testing, for example, patients on warfarin therapy, in hospitals, both in the trauma and emergency facility, but also just in bleeding patients presenting to the hospital, in community clinics to support treatment and referral decisions, in other clinics, in the doctor's office, in the pharmacy, etc., etc. So point of care testing being performed almost in all areas of the medical healthcare facilities. And the sample, either whole blood obtained with a finger stick, or whole blood from a formal phlebotomy, or whole blood from an indwelling line. There are even trials and studies now where urine is being utilized to perform various coagulation tests on. What is available for coagulation as far as point of care is concerned? If we look at the test parameters, I've decided to focus on the INR, or the International Normalized Ratio, also DOAC activity testing, the direct oral anticoagulants. Let's look at D-dimers, at platelet function testing, and also what about continuous ongoing anticoagulation monitoring of patients that are in ICU on ECMO or left ventricular assist devices, or in patients pre-invasive procedures. So the test parameters, and I'll be focusing on these 4 arenas. There are more, but we'll focus on these. The setting, as we've said, is throughout the medical treatment facilities, from primary healthcare clinics right to intensive care units. The clinical scenarios are very well known to us, either patients on anticoagulation therapy, patients that are being screened for venous thromboembolic disease, Prognostication, D-dimers and COVID, we know it's all. Suspected DIC can be excluded with a D-dimer level. Patients on antiplatelet therapy, patients that are bleeding might benefit from platelet function testing. And then we'll just also touch on ECMO and ongoing anticoagulation monitoring in those patients. What about INR? Studies have shown that INR point-of-care testing is used by up to 50% of Australian, American, and British GPs or primary healthcare physicians. So point-of-care testing for INRs are very well utilized. At our center, we validated 3 point-of-care INR instruments, namely the Coagulation XX, the Mission PT coagulation monitoring device, and the QLabs monitoring device. These validations entailed comparing the results obtained on finger stick capillary blood analyzed on point-of-care analyzer with the formal phlebotomy samples analyzed on automated coagulation analyzers in the laboratory. These results of INRs obtained on these two different test methodologies are compared, and we will then assess the accuracy of the point-of-care instrument. There are guidelines from organizations such as the International Organization for Standardization, published a guideline as to the targets that needs to be attained when these validations are being performed. But if we just look at what results we obtained on the Mission point-of-care INR device, it is very clear from this table, and I'm being facetious because it's not very clear from this table, but I will point out what I'm trying to demonstrate. I'm trying to demonstrate that the diversion between the results obtained on the point-of-care instrument compared to the formal result in the laboratory increases as the INR level increases. So between 4.5 to 6, there is greater difference between the point-of-care analyzer results and the formal laboratory results. And that's very well known, is that the point-of-care INR devices lose accuracy as the INR level actually increases. But accuracy for this instrument was demonstrated for expanded and narrow clinical agreement across the spectrum of INR results from 1.2 to 6. So this is now a concept that we also maybe just need to mention, clinical agreement, which is different from the actual numbers in the laboratory. So clinical agreement just basically means, are you going to increase or decrease your warfarin dose, or are you going to continue on the same dose? And at the end of the day, clinical agreement might be more important than the actual physical numbers in the laboratory. As far as reproducibility is concerned, because reproducibility is also a very important parameter whenever a validation is performed, reproducibility means that the same sample is analyzed repeatedly and the result is compared. For the point-of-care INR device, reproducibility with intra and inter-run percentage CV on control material was performed on normal and pathological controls. But we also recognize that control material, which is bought commercially from the suppliers, the manufacturers, differs from biological samples. So on our validations of the point-of-care INR instruments, we also actually had a normal volunteer that offered to donate capillary blood repeatedly in order for us to demonstrate the reproducibility on the point-of-care instruments that we validated. I somehow seem to be stuck. Oh, there I go. So point-of-care INR tests are attractive in remote, resource-poor locations and also in emergency departments. And I became aware of this when I attended a seminar around thrombolytic therapy for patients that presented with ischemic strokes, in that their INRs had to be, if I remember correctly, below 1.5 or 2. And there were seconds or minutes was at play here. So even in the emergency department, a point of care INR analyzer can be of great utility. The advantages: quick result, wide reportable range, the test strips are stable for a long time, small sample volume, small size of the instrument, built-in communication port with printers and with the laboratory information system, so results don't just disappear. They are there on the point of care instrument, and they can be printed or they can be stored. It's also been demonstrated that point of care INR testing does not lead to more major bleeding or more thrombotic events versus standard laboratory testing. There's also increased time in therapeutic range in patients that are offered point of care testing. Patients actually, some of patients actually prefer point of care capillary blood to be tested. And the point of care INR tests can be cost effective in areas where the laboratories are difficult to access. What are the caveats? Because there are always caveats. You need ongoing quality assurance. So there needs to be calibration of these instruments, as well as controls needs to be run. And that is what pathologists actually busy themselves with. So there is going to have to be some information given to the operators of these point of care instruments. Point of care INR values that deviate more than 15% from the laboratory results can result in incorrect management decisions. Values above the target range need laboratory confirmation, because we've seen that divergence between the formal laboratory results and the point of care results as the INR starts increasing. The operator needs training, and we always have to keep in mind the long half-life of warfarin. So changing the warfarin dose today will probably result in the same INR result tomorrow. And then if it's an untrained operator, that operator may then, the patient themselves, may then decrease their warfarin dose further, which is inappropriate. What about the direct oral anticoagulants? These drugs are fast replacing the vitamin K warfarin-based anticoagulants. These drugs, DOACs, rivaroxaban, dabigatran, edoxaban, are now available across the globe and also in South Africa for the prevention and treatment of thrombosis, as ischemic stroke, pulmonary emboli, etc. The anticoagulation activity will have to be assessed in certain situations, for example, if a patient is bleeding, or if there's breakthrough thrombotic events in a patient on DOAC therapy. Before invasive therapy, the surgeons will want to know what the level of anticoagulation is in this specific patient. Activity tests are not currently available as point of care tests for the DOACs. This may limit emergency decision making due to laboratory turnaround times, but there are publications coming through on the literature. For example, this is point of care testing for dabigatran and point of care testing for edoxaban. So definitely point of care testing, as far as the activity of DOACs are concerned, are on the horizon. What about D-dimers? D-dimers are formed, as we all know by the breakdown of fibrin clot called fibrinolysis. D-dimers are useful in the diagnosis of DVTs, PEs, and disseminated intravascular coagulation. Also prognostic in the recent COVID pandemic. And the tests for D-dimers all entail monoclonal antibodies that bind to the D-dimers that are present in the patient's sample. So just schematically, we've got a fibrin clot The molecule that's important here is plasmin, produced from plasminogen, acts as a pair of scissors, and the breakdown product, fibrin degradation product, are detected in the bloodstream. An example of that is the D-dimer. And we can just see here again the cross-linked fibrin molecules and the end result of plasmin degradation being the D-dimer. Now, we are stepping back into the laboratory, because what you see in front of you on the screen, hopefully I'm still connected to everybody, it is just the laboratory D-dimer assays that are available to us in the laboratory. We see the assay name here, the manufacturer, the methodology, the units that the D-dimers are reported in, as well as the manufacturer cutoff, and whether these different assays are FDA approved and whether they've got FDA approval for the clearance or the exclusion of venous thromboembolic events. So in the laboratory, a very complicated situation. For example, at the moment in our laboratory, we are utilizing the Stay Lie Test D-dimer from Diagnostico Sago. It's a quantitative latex-enhanced immunoturbidimetric immunoassay, reported in fibrinogen equivalent units in micrograms per mole, and the cutoff is less than 0.5 micrograms per mole. And it does have FDA approval for the exclusion of venous thromboembolic disease. So in the laboratory, D-dimers, a very complicated situation. And when we step into the point of care arena, where a D-dimer is now measured close to a patient, in this situation, for example, in an ICU, we see that the situation is just as complicated. Various assays, various manufacturers, the methodology is very much similar, but the unit types and the reported units, the manufacturer cutoffs are quite variable, and very few on this list of mine. I don't think it's an exhaustive list by all means. There's only one of these assays that has the FDA approval for the exclusion of venous thromboembolic disease. So D-dimer assays in the laboratory as well as outside of the laboratory, offered as point of care tests, very complex, very interesting situation that we have to be cognizant of. Point of care testing for D-dimers has been evaluated in various research papers. For example, point of care tests versus laboratory D-dimers assays have been demonstrated to often result in contradictory results in studies. Examples of these studies are, I've just listed three here. Baker, for example, point of care D-dimer by site triage assay versus lab Stego Lie test. Then Sen et al., point of care Alere triage versus lab Werfrin laboratory testing platform. So a lot of heterogeneity as far as the studies are concerned, reflecting the various assays that are available both for point of care and formal laboratory testing. These studies will then assess the sensitivity, specificity, positive and negative predictive values, and the cost effectiveness of the point of care test platforms. Even in the laboratory, there's significant interlaboratory variation in D-dimer results. The question is why? And this variation has been documented by the College of American Pathologists in a survey of 3,800 laboratories. There's high inter-method coefficient of variance, and this is due to inter-patient heterogeneity as far as D-dimer molecules and structure is concerned, which is influenced by the age of the patient, the genetics and the disease, hereditary and acquired coagulation deficiencies, the size of the blood clot, the timing of the specimen collection, etc., etc. The intermethod coefficient of variance is also influenced by the type of monoclonal antibody that is present in the assay reagent, and these monoclonal antibodies have got different specificities. There is a lack of standardization of certified calibrators and quality control material. There's also a lack of standardization of the reporting units for D-dimers, and there's inappropriate cutoff values that might, in certain circumstances, be too high for the exclusion of thromboses. What about the lack of standardization of reporting units for D-dimers? If there is lack of standardization of D-dimer reporting units, it may compromise test utility. D-dimers can be reported in two different units, namely fibrinogen equivalent units and D-dimer units. FEU is based on the mass of fibrinogen and is about 2 times, to be more exact, 1.7-fold that of a D-dimer unit, which is based on the weight of a D-dimer. So if we have to convert D-dimers to FEU units, we times the result by 2. D-dimer units results are also reported with as many as 9 different units of magnitude, which I've listed over here. In a survey, it's been found that in a survey of 1,500 laboratories, 33% of these laboratories that also did not comply with the recommendations of the reagent manufacturer for reporting of D-dimer results. And just a reminder, we are now in the laboratory and we're not even in the point of care arena. What about platelet function testing? When we talk about platelets, we are talking about this guy over here. Red blood cells, easy to recognize and to test. White blood cells, same, not so difficult. We can see them and we can do a lot of testing on them and get accurate results. But it's this guy that gives us a lot of problems. There are multiple point of care platelet function tests available. But the question remains whether in vivo thrombotic profiles can be assessed in vitro by the stimulation of platelets by a single agonist such as collagen. So when you take platelets out of the body and you expose the platelets to one agonist, namely collagen, adrenaline, thromboxane, does that reflect the in vivo situation inside the patients as far as their thrombotic profile is concerned? It has been demonstrated that adjusting antiplatelet therapy according to point of care platelet function tests did not decrease the cardiovascular disease event rate. And this is probably due to differences between the in vivo point of care, in vitro point of care platelet function tests and the in vivo conditions inside the patient. There are therefore important limitations of most point of care platelet testing platforms. And I'm just almost saying these instruments are small enough to sit in a cardiothoracic laboratory, to sit in a theater. So the point of care instruments lend themselves to function as point of care tests. But we have to remember that there are many limitations. And these limitations will now refer to both testing that's performed in the laboratory and testing that are performed near the patient. Because these analyzers will probably be the same analyzers that are just used in these two different locations. Citrate inhibits platelet function, but we collect all our samples for platelet function testing in citrate tubes. There's also no flowing of blood in platelet function test analyzers. And when there is no blood that is flowing, we are unable to assess the shear stress which can result in platelet activation. Fibrinolysis, which is a determinant of the outcome of cardiovascular disease, is mostly also not assessed on these platelet function test analyzers. There's also no assessment of the other blood constituents, namely the red blood cells and the white blood cells in thrombus formation, when we are testing platelet function on platelet function test analyzers. Now, this is a complicated slide. I mean, what is a hematology talk at almost 4:30 in the afternoon if there isn't a complicated slide? But on this slide, we can see, this is a slide, again, not exhaustive, but just of all of the platelet function and analyzer platforms that are available to us. In the first column. The second column, again, the manufacturer. And then we've got, for example, here we've got the anticoagulants, examples of anticoagulants that are being used on these instruments. We can see how the thrombus formation is stimulated on these analyzers, whether the contribution of the red blood cells and the white blood cells are assessed, whether flow is created, and if flow is created, whether shear gradient is achieved, and whether we can assess the endogenous thrombolysis or thrombolytic function in the sample on these platelet function analyzers. And when we then start looking down the table, we can see a lot of no's. And then we come to the last analyzer here, which is called the Global Thrombosis Test. Sorry, global, it's very faint on my screen, but I hope it's clearer on your screens. The Global Thrombosis Test from a manufacturer in London. And interestingly enough, this test platform requires no anticoagulant in the sample that is collected from the patient. High shear generates platelet activation. There's no agonist added. So the contribution of red blood cells and white blood cells are tested on this platform. There is blood flow is simulated on this analyzer. And there's also pathological shear generated on this testing platform. And we can also assess the endogenous thrombolytic activity of the patient on this platform. It gets a thumbs up, and I think now I have to just say that I don't have any conflict of interest, so I am not sponsored by this company at all. But this seems to be the analyzer that we will be working towards having in our laboratories. This kind of analyzers similar to this platform stands in contrast to analyzers that are well known to us or better known to us, for example, the PFA 100 and 200, with a lot of no's in this table of platelet function analyzers. What about anticoagulation monitoring in the ICU or pre-invasive procedures? And we became aware of ECMO again, unfortunately, during the COVID pandemic, where patients with reversible pulmonary failure or with cardiogenic shock were offered ECMO therapy as a bridge to, for example, left ventricular assist device, or during a time where we think pulmonary function will return. But these patients on ECMO therapy will be under continuous risk of bleeding and thrombosis. And anticoagulation or antiplatelet agents are required to mitigate against the risk of bleeding or thrombosis. As far as anticoagulation and antiplatelet agents are concerned, and to mitigate against the risk of bleeding, we will have to continuously assess the level of anticoagulation in these patients. And therefore, point-of-care testing has become very attractive in patients on ECMO therapy, because point-of-care tests can be performed, result immediately available, and the level of anticoagulation or antiplatelet agents in these patients can be adjusted. Conventional laboratory tests of hemostasis have got limited efficacy in ECMO, in patients on ECMO therapy, and may delay the detection of hemostatic disorders and result in misguided and excessive use of blood products. The tests that have been utilized include the activated partial thromboplastin time, the prothrombin time or the INR, activated factor 10A assay, the activated clotting time with protamine that removes heparin from the sample, TEG analyzers or the ROTEMs have been used, platelet function tests have been used, but the optimal monitoring assay for anticoagulation or ECMO still remains to be determined. And I know that it is actively being investigated. I've recently marked an MET concerning the most optimal form of anticoagulation monitoring in patients on ECMO therapy. And then I thought that was the end of my talk. But Estelle Verburg phoned me on Friday afternoon. She said, Susan, are you going to say something about the TEG? So I thought, okay, fine. So then I thought, let me just say something about the thromboelastogram. So this picture over here just reminds me again to point out that the thromboelastograms at Charlotte Maxeke Johannesburg Academic Hospital, now being called SIMJAR, was first in the cardiothoracic units. That was in the cardiothoracic laboratory. But the analyzers were eventually brought down to the laboratory and is now in the formal laboratory here in our hospital. And the reason why they were brought down to the laboratory again was due to reagent control, due to stock availability, due to operator training, due to quality assurance, due to the availability of previous analytical result. So in other words, we did a TEG last night. Where is it now? Because following on that TEG, we did X, Y, and Z. So now we want to compare the TEGs, but we can't find the printout of the previous TEG. So the analyzers are now not in the optimal place. They are in our laboratory. And hopefully, eventually, we can again get them back to where they need to be in the cardiothoracic ICU. But this analyzer functions on the principle of a cup, whole blood, citrated whole blood is inserted into the cup, which then oscillates through various degrees. There's a torsion of a wire that's connected to the cup. Eventually, the blood, after an agonist has been added, will start clotting, and the tension that's created by the whole blood that is clotting will be translated via the tension wire, and a graph will be generated, which indicates the R time to clot formation, the K time, and the maximum amplitude. And we can deduce various parameters from this forming clot, and hopefully we can then, based on these parameters, the R time, we can then administer various products such as FFP, because if the R time is prolonged, it has been demonstrated that this is dependent on clotting factors, and FFP will make a difference. The K time is the time to achieve a specific clot strength, and this is dependent on fibrinogen. So treatment will rely on cryoprecipitate replacement therapy. The alpha angle assesses the rate of clot formation and is also fibrinogen dependent, so again cryoprecipitate. And the maximum amplitude, that's where we will go to blood bank and get platelet concentrates for the patient. And the clot breakdown, LY30, antifibrinolytic patients may assist a patient that is bleeding and that has abnormality with the fibrinolysis. So is this cast in stone? Can we say that this is definitely been proven above any doubt that this is of utility in patients, and it is still an area of active research? But in our laboratory, as I say, we do have 2 analyzers we do put the results on our laboratory information system, and the clinicians at our hospital definitely find utility in the results they obtain from the TEG analyzer. And then just the different patterns on the TEG analyzer that will indicate to us whether the patient will benefit from replacement either of coagulation factors, of platelets, or of antifibrinolytic therapy. So in conclusion, I feel a little bit of a steam train, and it was a little bit fast, I think. But in conclusion, point of care testing is here to stay. As far as I know, and I've been told by a very, very reputable source, that one of the private laboratories close to Charlotte Maxeke, Milpark Hospital, now has a laboratory that is filled just with point of care analyzers. It's a point of care laboratory. So point of care testing is here to stay. But we as pathologists have to always remind clinicians and our colleagues that there are caveats. The cost effectiveness of point of care testing is difficult to gauge, and cost comparison against traditional central laboratory testing is complex. There can be initial costs for the implementation of point of care testing systems, since these costs can be high. The allocation of budgets for point of care testing is not appropriate, and reimbursement and billing is a major hurdle for point of care test implementation. Quality assurance is another hurdle that needs to be overcome, as well as accreditation of point of care testing facilities. There's also a lot of regulatory issues as far as this testing platform is concerned. Device operation by untrained or non-competent staff can result in results that will ultimately harm patients. Inconsistent quality control procedures can also result in incorrect results with disastrous outcomes. And reagent management is basically a full-time job in the main laboratory. The storage of reagents, the ordering of reagents. Whenever I walk into the lab and the coagulation supervisor, I see her and I say, "What are you?" She says, "I am busy ordering stock." So it is a full-time job just to make sure that all the reagents are in the laboratory and the reagents are stored, cold chained when it needs to be, and prepared in a correct fashion. Device performance, as far as point of care testing is concerned, connectivity and data management issues can result in reduced analytical performance compared to the laboratory testing that happens, formal laboratory testing. And I'm not just saying that because I'm a pathologist, but I'm saying that because it is these are real issues that we need to discuss. So when it comes to point of care testing, and you've got some lifelines, I would suggest phone a friend, because this environment is complex with a lot of caveats. Yes, patients can definitely benefit from point of care testing, but it has to be handled in the correct way with the correct quality assurance measures in place. Thank you very much. And over to you, Jessica. I see there's one or two things in the chat. I'm just going to have a look there. I'm just going to stop sharing.
Yeah, so thank you for an absolutely brilliant talk. That was really a tour de force. Just one question so far is regarding the activated clotting time. Is there any role for the ACT anymore? For example, one of our participants has mentioned in abruption. Would there be, is that still available? Are they still being performed, and what is their role?
Sure. So the first question, I can't answer it. The last time I heard of ACT, and I hope that there are colleagues on the call this afternoon that can help us, was in the cardiothoracic unit. So post-cardiothoracic surgery, ACTs, as far as I'm aware, was still being performed, especially then with protamine to remove the heparin, because we all know that cardiothoracic surgery and heparin go hand in hand with bypass, and to remove the heparin and then to see the endogenous coagulation of the patient. The ACT I came across was being utilized in the cardiothoracic unit, but maybe some other colleagues on the call can shed some more light. I've not heard of it in the obstetric units, but please inform us.
Yes, I agree. I've also, I mean, I don't know that it's being used anymore, but from what I remember, it was if a patient's very sort of over heparinized, that, you know, when the heparin levels are too high to measure with an APTT, for example, that you could use the ACT. Jennifer, I'm not sure if you want to perhaps unmute yourself and just explain the context if you used to use this before in an obstetric environment.
Thank you. We used to just do it with the clotting time in a tube that had no anticoagulation in it. You'd put a few mils in the tube, you'd put one in your pocket and you'd rotate it every 30 minutes, every 30 seconds rather, and you'd have a look. And when it clotted, that was your clotting time. And I used to say, not just with the first clot, when it clotted completely. So it wasn't just an activated clotting time. It wasn't as fancy as that. It was an immediate test that you did yourself. And it said there's a problem with coagulation now. I was interested in trying to look at it and comparing it to the other things as well. You'd still have to do tests and order things. But I mean, abrupture placenta is horrible. And it comes in with that. You can have unbelievable clotting problems. Okay. So we didn't have any of these point of care things. Peter Wessels is going to give me the answer there. Thank you.
Thank you, Pete. Go ahead.
You know what? The bottom line is, if you get a heparin level more than 1 unit, international units per mil, in other words, remember, we're doing anti-10s and we're looking at values 0.3 to 0.5 or 0.5 to 1, or maybe 1 to 1.2 for valves. If you have values above 1, then you can do a activated clotting time, but there's instruments lately that can do it much more accurately. It's a point of care ACT instrument with a little cartridge that they use in thoracic surgery. And that's where because they give this very high dosages of heparin whilst working, especially open heart surgery or whenever whatever they do and mess up. And then they need to reverse, and that's where they use it, because a normal APTT will be too prolonged, an anti-10 will be too prolonged. So it's a crude method of measuring very high dosages of heparin, but there's nobody using that old way of having a tube, turning it around. There are instruments. We had one of these instruments. The problem with that is that it's a lovely little cartridge, and all the sisters in the theater love to take it down and play with it and give it to their children. And so it's very difficult to control. That's the big thing with point of care, is control of the instrument and the reagents. But ICT, it's something that it's still being used. It's not monitored the old way. There are instruments where we can use it. We've looked at it. We've used it before, but the problem is to control, because it's very high cost. It's to control the cartridges, but the instrument is available.
Thank you.
Thank you very much. For those of you that don't know Dr. Wessels, he is a very eminent coagulation expert in the private sector in Gauteng, and I'm actually very interested to hear, Peter, if you've got any other comments from your perspective regarding point of care tests and coagulation.
I'm biased, so I studied at Tuks with Professor Frans, and we used the TEGs, so I'm really biased. I love the new TEG 6. I think it should be in every unit. The big advantage of the TEG6 is that even an orthopod can use it. You can't break it. It's easy to use. It can fall. It's a robust instrument. The only thing is that you can't. It's not viable financially. But I wrote a recent editorial for the South African Journal of Anesthesia, and in that I said, the long path that we had until today, where we now accept TEG as an instrument that has a place in hematology and in the lab. I think it's a long history that we have, and I think it's a fantastic instrument. They're even looking at, they actually 3 journals, seminars in thrombosis and hemostasis had 2 specific volumes just on TEG and the use of the TEG. So I personally like it, but I'm totally biased because of Professor Frans. And Barry Jacobson is also biased. He did his MEd on the TEG. So if he's on this, he must support me.
I'm not sure if I haven't seen him on the call, but I have got a question from Prof. Kutsia. Marius Kutsia, what is the cost of a TEG6 test at the moment?
Unfortunately, Marius, exceptionally expensive. That's the problem, because you see what the TEG6 does. It's got a cartridge that measures like the Rotem. In other words, the TEG has now moved from just being an instrument with a little pin that moves, that you have now a cartridge where you have activation. You can do a sort of like an in-tem and an ex-tem. In other words, you can add silica to do a PTT. And the big advantage is these are whole blood testing. So it's really, and you can do a FIPTEM where you remove the influence of the fibrinolytic system, and you can measure the platelet function. So these are really fantastic instruments. And for example, in Germany, if you're in a car accident, you immediately will get a Rotem or a TEG6, because it's the only way to immediately diagnose hyperfibrinolysis. So it's fantastic instruments, but due to funders not paying for it, it's not the test that is so expensive, it's the instrument. I think the instrument is about 600,000 Rand, just the instrument. And then the cartridge, to be viable, to be able to use it in private practice, you will have to charge double the cost of the cartridge, because if you make a mistake, you need to be able to repeat it, and that they will never pay for it. So it's a huge issue. I believe in the TEG, and I think because there's a very good article on the use of the TEG compared to traditional tests, and the article ends with the answer or the conclusion: it's not either or, it's both. Especially in bleeding, we've had a huge, massive advantage using the TEG in bleeding patients. But the move now is towards seeing the hypercoagulable state on a TEG. In the past, we said we couldn't, but with the additionals, they're even now looking at DOAC levels on a TEG6. So I'm biased, but I like it.
Thank you very much, Pete, for those comments. I've got Prof. Chapanduka from Tygerberg Hospital with his hand up. Please go ahead.
Yeah, thanks, Susan. Thanks, Jessica. And thanks, Dr. Veso. Now, the points you make about cost are really relevant. Oh, what's happening? All right, they're really relevant because the promise of point-of-care testing included lowering of costs. That's why all of these funders and administrators are seduced by the promise of point-of-care testing. However, when you look at, if you take an inclusive costing model, our point-of-care testing in this country, and I don't have the hard figures, but I did a rough estimate, are too high, so that the promise of cost cutting is not met. And that's the point which has just been made. It is rich, so they can sell more. They can sell to clinics and nurses and GP practices. So in terms of business, it's really big business. But on the cost score only, I don't think point of care testing is in any way money saving. The second comment I want to make is around the quality. Well, let me talk about the third point. The third point is that as hematologists, we miss the bus. In the 90s, during my registrar days at King Edward, Labour Ward was already using the TEG. Jack Moodley was a big, Professor Jack Moodley was a big proponent. When they tried to do work with us in hematology, we took the view that, look, this is too crude. We don't have control over the quality and all of that. And we missed the opportunity for a hybrid model. Now, the labs who are bringing point of care close to the institutions, close to the hospital, or even opening a point of care room within the hospital or near patient testing. That is the model which, in my opinion, we need to pursue, whereby we maintain the control of the instruments. We have a point of care department which runs point of care instruments at all the major sources of samples. I've got experience with this because in Saudi Arabia, when I was chief of pathology, one of the things that we did right from the start was to try and get accreditation from the College of American Pathologists for a unit which deals with point of care testing. And many, many years later now, the central laboratory controls the point of care testing, and the costs are considerably cheaper. So that it's also good for the laboratory, instead of investing in a phlebotomist, in tubes and the testing and all of that, and losing so much time, we have somebody who's on the spot and they'll do this for a cheaper amount. Now, the other concerns which Susan mentioned around quality and all of this, these are major issues. And until we can really say that we have enough programs which can monitor the quality of what is happening there with all the point of care instruments, I think we won't be there yet. But we got to embrace point of care testing. And I'm a bit disappointed with the NHLS in this regard. For the past 6 years that I've been in the NHLS, we've been talking about point of care, but I'm not seeing any progress here. So my admonition to the powers that be is let's move on this one. Thanks, Jessica.
Thank you very much for those comments. Very interesting and pertinent. Susan, would you like to respond? And also there is a question about viscoelastic instruments. Can they be used to decide about tranexamic acid? That's also from Prof. Kutsia.
Good afternoon, Maurice. Yes, as I've indicated in my talk, if cyclocapron can be utilized if the fibrinolytic system is overactive, and that can be demonstrated on a TEG analyzer as well. So I think the answer is yes. So thanks for that question. In comment to Professor Chapanduka's query comment, yes, I'm part of the point of care validation or implementation group of the NHLS, and hopefully something will happen before I retire, but I have also been busy and on this group for quite some time. So hoping that we're going to get there, but I share your concerns.
Fantastic. So are there any further questions or comments? I'm not seeing, oh, I've got slide control. So just to remind you that CPD points will be automatically submitted to the HPCSA for each of you. And I'm very pleased because we have just made the 60 minutes of attendance to get our HPCSA points. So thank you very much, everybody, for attending. This was a very useful, interesting, pertinent topic. And thank you very much, Susan, for really explaining it so clearly, and it's in such an easily understandable way. Really appreciate it, and thank you for all the questions and the discussion from colleagues as well. So with that, I'm going to say goodbye and have a lovely evening. And Susan, would you like to say some last words?
Yes, I just want to thank you for the invitation and for listening to a topic that I think can be quite dry on a Monday afternoon. So thank you. And I'm hoping to see you again on the next deep dive. Maybe Pete can even give us an overview of the pegs, which I kind of was running away from. So thank you very much. Thank you, everybody, and have a good evening.
Okay, thank you. Bye-bye.